נמצא איתנו פרופסור מויזס סקלו, הוא פרופסור אמריטוס לאפידמיולוגיה באוניברסיטת ג'ונס הופקינס, עם מינוי משותף בקרדיולוגיה. הוא יליד ריו דה ז'ניירו, ברזיל. הוא סיים תואר דוקטור לרפואה באוניברסיטה המקומית ולמד לתארים מתקדמים בבריאות הציבור בג'ונס הופקינס. פרופסור סקלו הוא מחבר של למעלה מ-350 מאמרים, לדעתי זה בצניעות מטורפת, זה כנראה בפי 2 או 3. והוא כותב של ספר הלימוד המוביל בשיטות אפידמיולוגיות, Beyond the Basics, מי שהאפידמיולוגים פה בחדר. הוא שימש כעורך ראשי של ה-American Journal of Epidemiology במשך 31 שנה, ופעם דיברנו והוא אמר לי שהוא כל יום עושה סקרינינג ל-20 papers, שתבינו את הפנומן. הוא חוקר ראשי של אתר הופקינס במחקר העוקבה ARIC ו-MESA study, וכיום הוא יושב ראש ועדת הפרסומים של ה-MESA, שבחנה מעל 2,500 מאמרים שהוגשו לה. הוא חוקר גורמי סיכון קרדיו-וסקולריים בקרב 80,000 בני נוער בברזיל. הוא זכה בפרסים רבים על תרומתו המדעית ועל חונכות ומנהיגות, וקיבל הוקרה מאוניברסיטאות מובילות בעולם. פרופסור סקלו ידבר איתנו באנגלית על the importance of the natural history for public health policy, וזו הרצאה שתכין אותנו לקראת השולחנות העגולים. Professor Szklo, the floor is yours.
Okay, thank you very much for your kind words. Even though I don't understand Hebrew, I'm sure the words were kind. I think it's nice to be here. I want to thank Rachel for the invitation. I also want to thank Lior for his assistance. So we're going to be talking about natural history of disease, but I want to use cancer as the example. So what is the natural history? The natural history shows how disease evolves. So the first phenomenon is the onset of exposure to risk factors, and then the biological onset of the disease. And at that time of the time of the biological onset, disease usually cannot be identified. And then after that, early detection becomes possible. But there could be also detection at the beginning of the clinical phase based on symptoms or signs. And the time between when early detection becomes possible and the clinical phase, the beginning of the clinical phase, is what we call detectable preclinical phase, very important. But of course, early detection doesn't happen as soon as early detection becomes possible. So there's an interval, and the difference, the period between early detection in practice and the beginning of the clinical phase is what we call lead time, very important concept. And then there could be also detection after the beginning of the clinical phase, which is really a delayed detection of the disease. And finally, you can have cure, death, or disability. So this is really the natural history of the disease. Now, in public health, in public policy, we recognize different kinds of prevention. So you have the primary prevention, which is everything that happens before the disease starts. And inside the primary prevention period, you could have prevention of exposure, which is the best way, really the most efficacious way to control the disease, or cessation of exposure. So prevention of exposure is also known as primordial prevention. And then you have secondary prevention, screening. It can be of two types. It could be population-based, or it could be case-finding, opportunistic, and we'll be talking about that. And then you have tertiary prevention, which is really prevention of death or disability. Now, let's talk a little bit about secondary prevention, which, is screening. And the purpose of research is to make the lead time as long as possible. And ideally, the lead time should start almost after the biological onset of the disease. This is the better way. And of course, if the lead time starts at the biological onset of the disease, the lead time and the detectable preclinical phase are the same, right? So this is the purpose, to find tests and procedures with high sensitivity. Sensitivity is so high as to allow the lead time become the detectable preclinical phase. Okay, so that's it. Biological onset is the time when early detection becomes possible. We don't know any disease in any screening test that does that. All right, so there are some important assumptions, of course. And one important assumption that most clinical cases have a detectable preclinical phase. If there's no detectable preclinical phase, then, screening doesn't mean anything. And then, this is very important, without therapy, most cases in a preclinical phase will progress to a clinical phase. And we know that that's not entirely true. And the best example, which I'm going to discuss a little later in the presentation, is prostate cancer. So, prostate cancer is a great example because in prostate cancer, not all cases in the preclinical phase go on to the clinical phase and invasive disease. We'll talk about that in a little while. So I'm using cancer screening as my example of the importance of natural history in control of disease. And of course, there are a couple of cancer screening strategies. One is removal of precancerous lesions. The classical examples are cervical cancer and colorectal cancer. Or early detection, again, cervical cancer, colorectal, breast, lung, and prostate. Those are the best examples of screening that is going on in the United States. Okay, now we cannot talk about the importance of the natural history in policy, public health policy, without saying something about translational research. And this is the definition that I came up with. And the reason I came up with this definition is because I couldn't find any other definition in the literature. So what is translational research? It's actually effective transfer of new knowledge resulting from studies and trials into the planning of population-wide and individual-level disease control programs and policies. And again, I'm going to use the prostate cancer as an example of translational research. Now, we have to distinguish translational research from implementation science. Implementation science is really the logistics. It seeks to understand the behavior of healthcare professionals and other stakeholders as a key variable in the sustained uptake, adoption, and implementation of evidence-based intervention. Now, after the lecture, I'm going to pass on all my slides to Rachel. So if you wanted to consult some of those sites, you have the slides. Okay, so this is Goethe. Of course, you heard about Goethe. Okay, Faustus, Werther, and he says something wonderful. Knowing is not enough. We must apply. Willing is not enough. We must do. And so, how do we do knowledge translation? So what I'm going to show you is really an ideal process. I'm not saying that every single public health action or policy action should be based on this process. But it's a good idea to have it in mind as the ideal process. So you want to you want to approach the process as much as you can. So of course you start with evidence, ideally randomized trials, but not always. In fact, sometimes policy can be made on the basis of a single study, like a case control study. You remember the toxic shock syndrome? It was the policy was based on a single case control study showing that tampons were contaminated. Okay, and then we go to the evaluation of levels of evidence and then evaluation of programmatic options. It's too bad I don't have the time to talk about decision analysis, which is very important in evaluating programmatic options and allow us to distinguish efficacy from effectiveness. But let's talk about, and then we can have sensitivity analysis. Again, we don't have time to do that. Then you do cost effectiveness, and again, with or without sensitivity analysis. And then recommendation, evidence-based policies. And there's always a tension between evidence and obstacles. And those obstacles can be ethical, can be of politics nature or resources. So this is really the ideal knowledge translation. Now, let's talk about the evaluation of levels of evidence, a very important step in translational research. So this is based on the United States Task Force and also the Canada Task Force. So we have levels in definition. The highest level, the best level, is at least one well-designed randomized controlled trial that has shown that the intervention or the policy does more good than harm. This is very important. Then you have the level below, which is, they call it 2-1, well-designed cohort or case control analytical studies, preferably multi-center, suggest that intervention does more good than harm. And then dramatically, about below that level, there's Roman 2-Arabic 2, dramatic results in uncontrolled experiments. We call it natural experiments, suggest that the intervention does more good than harm. And you know about the insulin. Okay, the insulin was discovered. Case fatality of diabetes went down precipitously. You didn't need a clinical trial to show that. And there are lots of examples in the literature. So, and then the bottom level is really when authoritative and respected experts in the field are convinced of the value or lack of value of the intervention. This is really not a science or evidence-based. Okay, and then you have translation and implementation. Just quickly, remember William Farr, some of you may know, he was an actuarian in United Kingdom in the 19th century. And he said, that is a fact, all else is inference. What do I mean? I mean that from now on, after you have definition of the levels, or definition of the level, then there's a committee. So the committee is going to judge the level of evidence to make recommendations and suggest or not suggest implementation. For example, level A, there's high certainty the net benefit is substantial. Or B, there's a high certainty that the net benefit is moderate or moderate to substantial. And then what do? Well, you design and offer the program or the policy or the intervention. There's moderate or high certainty that the net benefit is small, then you design, offer, provide the intervention only if other considerations support offering or providing the intervention on a case-by-case basis. And then, again, I'm going to give you examples of that. And level D, there is moderate to high certainty that there is no net benefit, or that the harms outweigh the benefits. So it should discourage the use of this intervention. And finally, the bottom level is the current evidence is lacking, or poor quality of conflicting. And if the intervention is offered, the individual should know about the certainty, about the uncertainty about the balance of benefits and harms. So this is really a broad picture. They give you an idea of what the United States Task Force and the Canadian Task Force do. Okay, so those are the three classical or cancer sources of evidence. The U.S. Preventive Services Task Force, the American Cancer Society, and the Canadian Task Force on Preventive Healthcare. And I'm mainly going to use the U.S. Preventive Services Task Force. So remember that each one of the level of evidence, the definition includes that states very clearly that the intervention does more good than harm. Okay. And so this is very important. Let's talk about prostate cancer. So does it do? Does screening for prostate cancer does more good than harm? Well, you have sensitivity and specificity, and prostate-specific antigen is used as a screening tool, and if it is equal or more than 4 nanograms per milliliter, it's considered to be positive, okay? So the problem is that neither the sensitivity, the specificity can be high, but even so, the sensitivity is not terribly high. So of course, if the specificity, if most people don't have prostate cancer, even a specificity of 91% will give you a lot of false positives, number-wise. So the percent of false positives in those levels from different studies is between 20 and 68%. So most people with a positive PSA do not have prostate cancer. Okay, and there are causes of false positivity, prostatitis, endoscopy, ejaculation, some medication, or what is more common, benign prostatic hyperplasia. But the problem is that until a few years ago, a positive PSA will lead to biopsy. And biopsy has complications: severe pain, 1/4, hematuria and hematospermia, almost half, fever, which means infection, 3 or 4%. So biopsy is not risk-free. Now, if biopsy is positive, it could be the prostate cancer can be potentially invasive or never invasive. And until recently, you have positive biopsy go straight to surgery or radiation therapy. Now, complications of surgery or radiation therapy, death, okay, if you do a lot of people, is not negligible in the population. But the main complications are urinary incontinence and sexual impotence. So the surgery and radiotherapy is followed by important complications. And the problem is that most cases, I wouldn't say most, but a high proportion of cases of prostate cancer do not kill. They do not progress to an invasive stage with metastasis, local and distant. So in this study, the tumor was found in more or less 1/3 of Caucasians, whites, and more than half, or about half, in African American. So we can say these are the people who died with prostate cancer, not from prostate cancer. So bottom line is prostate cancer is not invasive in a large proportion of patients. So I came up with a new definition of false positivity. Now, the classical one, individuals with positive tests, but with no prostate cancer. And this one, individuals with prostate cancer that never becomes invasive, okay? And until recently, we didn't know how to distinguish people in whom prostate cancer will become invasive, and those in whom prostate cancer will not become invasive. And this is a real problem. That's one of the reasons people decided to suggest radiation therapy or surgery. Okay, benefits of a valid and reliable screening test. Many screening tests are valid, reasonably high sensitivity and specificity, and reproducible. They detect the presence of disease in the detectable preclinical phase. But that's not enough. Does the use of this test for screening beneficially influence the natural history? To answer this question, we need to evaluate the effectiveness of the screening program using those tests. What is the influence of the screening program on disease outcome? This is the main question, right? And so, relatively recently, just before the pandemic, a meta-analysis was published in which there was a systematic review of randomized trials. And the key question was asked by the authors: is there direct evidence that PSA-based screening reduces cancer mortality and morbidity? Remember that at least one well-designed randomized controlled trial has shown that the intervention does more good than harm. And these are the trials with their different characteristics. And it's one of the things you have to pay attention in meta-analysis. The trials had different characteristics. For example, the age range varied. Okay, you can see that. The screening interval varies. The number of screening rounds varies. And the median follow-up also varies. Now, interestingly, with the exception of the two first trials, all of the trials show that the relative risk of mortality is less than 1. And therefore, the effectiveness can be easily calculated as 1 minus the mortality, the relative risk, 1 minus the relative risk of mortality. For example, in Gothenburg, the efficacy or the effectiveness was 42%. Okay, 1 minus 0.58. Now, you could say then, well, most clinical trials show some benefit. Well, you have to pay attention to the characteristics of the clinical trial, but they don't show the same results, but they all point to the same direction. Now we have something that's absolutely crucial, and that is reductions in prostate cancer vary from 42% right here and 15% here. However, there was no reduction in all-case mortality. This is what we call the public health effectiveness. So it does prevent prostate cancer, but it doesn't prevent death. And to this day, we don't know exactly what's going on. Okay, people are trying to study that because if prostate cancer goes down and mortality goes down, for the overall mortality to stay the same means that something is going up, right? Mortality is going up. So anyhow, what do they recommend? Based on those, on the meta-analysis, for men aged 55 to 69, decision to undergo a periodic prostate-specific antigen-based screening for prostate cancer should be an individual one. Before deciding whether to be screening, men should have an opportunity to discuss the potential benefits and harms of screening in their clinician and to incorporate their values and preferences in the decision. So going back to the level of certainty is moderate or high, is C. So the expected net benefit is small, and the implementation should be on a case-by-case basis because you have to explain to the patient with prostate cancer what the randomized trials show in terms of the overall, the all-cause mortality. And they don't recommend for people over 70 or over. So this recommendation, C, is for people 55 to 69. And the reason they don't recommend it is because, you know, at 70, your life expectancy is not too good. So, but again, I suggest against what the U.S. Preventive Services Task Force says, that you also should talk to the individual with prostate cancer about the plus and the minus, particularly the minus in terms of all-cause mortality. Okay, so you can see there's some subjectivity in terms of the recommendation. All right, so until recently, now there's a new strategy, and actually a strategy developed by Johns Hopkins. For men with low-risk disease, adoption of active surveillance rather than immediate definitive treatment. So they came up with a process, a procedure to determine the level of risk. And this is it. I'm not going to go over it, but the risk profile can be very low, low, intermediate, or high. So for each one of those risk profiles, there's a recommendation. But it means that you're not going to go straight to surgery, right? You may monitor those people, do surveillance of those people. And it's interesting, in prostate cancer, even if you have distant metastasis, hormonal therapy may extend your life expectancy by as much as 10 years. So this is the status of prostate cancer. Now, let's go to colon cancer, because colon cancer gives an idea of the importance of both primary prevention and screening. And here, what the task force recommends, okay, colonoscopy every 10 years, but more often if you have inflammatory disease, bowel disease or Crohn's and so on, then more often, maybe 5 years. A personal family history of colorectal cancer also, you should shorten the interval for colonoscopy. And then there's a genetic syndrome or non-polyposis, familial adenomatosis, polyposis, and so on. So, or you can do sigmoidoscopy every 5 years or every 10 years. If you do it every 10 years, you should do a occult blood. So this is a fecal sample. It's called FIT. And what is that? It uses antibodies to detect blood in this stool. It is also done once a year in the same way as the GFOBT, which is the classical occult blood. Okay, now the problem with fecal tests, they do not identify adenomas, polyps. They identify cancer. Now, of course, in some rare cases, the adenomas may bleed, in which case it can also, but the sensitivity for identification of polyps is very low. So they are not such an excellent way to do screening. And of course, and then you have the FIT, combines the FIT with a test that detects altered DNA in the stool, is done once every 3 years. So this is also a feces-based test. Okay, so it is important to develop options for colorectal cancer screening, as colonoscopy may not be acceptable, and even if it is, it's expensive. So colonoscopy for population-based screening doesn't work terribly well, even though the U.S. Task Force recommends it. So the fecal test, as I said, mainly identify cancer, not adenoma. Novel cancer, colorectal cancer screening tests, biomarkers devices that detect adenomas are needed. So research is needed to create a non-invasive test that is sensitive, or highly sensitive, to identify polyps. Okay, so what is the recommendation? Well, colonoscopy, okay, is A, okay, and for people age 50 until 75, and C for 76 to 85. Why is only C for 76 to 85? Well, because surgery, radiation therapy may cause complications, okay? And if you have a life expectancy which is not terribly long, you may want to live with prostate cancer and get hormonal therapy even if you have metastasis. So again, you see that it's not so simple. All right, so let's quickly talk about primary prevention. Now, primary prevention is the most efficacious. But of course, to have primary prevention, you have to have modifiable risk factors, okay? For example, a family history of breast cancer is an important risk factor, but it's not modifiable. But even if it's not modifiable, it defines a high risk group, which is important for screening and for prevention of modifiable risk factors. So we should not forget that primary prevention is the most effective and efficient strategy in cancer control. I would say any disease, not just cancer control. Now, colorectal cancer is amenable to primary prevention through prevention or cessation of environmental risk factors. And you can see the risk factors here and the optimal levels. So obesity, you should not be either obese or overweight. Inactivity, you should do, I think this is a little idealistic or maybe not terribly realistic. Equal or more than 75 minutes per week of vigorous exercise, or equal or more than 150 minutes per week of moderate plus vigorous exercise. Non-smoker, or less than 3 packs years. Alcohol, less than 15 grams a day. Red meat intake, less than 2 servings a week. And low folic acid intake, more than 100 micrograms from supplement. And if everybody had optimal levels, 71% of colon cancer is preventable. Isn't that something? This is incredible. All right, so conclusions. To finish my lecture, I have to abide by the 35 minutes that I was asked to abide to. So what are the conclusions? Both screening and primary prevention are needed for cancer control, although it is widely recognized that primary prevention is feasible, is more effective. Population screening is a key component of cancer control, again, any disease, but it offers important challenges. Continuing search what the important challenges, as we know, are the prostate cancer that goes to surgery or physical or radiation therapy, and colon cancer. In the example, the fact that colonoscopy is not terribly implementable. And then continuous search for more valid and reliable tests should be conducted with the purpose of increasing the detectable preclinical phase and therefore advance lead time. And remember that the ideal situation is when the lead time becomes equal to detectable preclinical phase. And although it is important to use tests with high sensitivity and specificity levels, the ultimate evidence in favor of effectiveness must come from comparing mortality in the screened and the control groups, which is ideally done in the setting of randomized trial. Okay, 35 minutes. Thank you very much. So Rachel, what do I do now?
Thank you so much, Moyses. Is there anybody in the audience wants to ask a question? I just want to give the context of this wonderful lecture. First of all, it's clear that we need good evidence before we implement policy, before we do anything. And we don't always have the evidence. And even if we have the evidence, we may not have the means to intervene. I'm a public health specialist, and I'm the first person to say that the primary prevention is the best way of prevention. And this conference is about healthy aging. So the best primary prevention is to start early, in kindergarten and in young age, and to preserve the healthy lifestyle as we go along. I'm sure, Moyses, you'll agree about that.
Absolutely.
We heard several talks about cognitive decline, about dementia, and I'm wondering how can we prevent these situations in primary prevention or secondary prevention with the tools that you just talked to us about?
Yeah. Well, that's a very important question. You know, the one thing that is, I would say, quote in quotes, good, is that a lot of the risk factors for cancer are also risk factors for cardiovascular disease, and also risk factors for dementia. Think about hypertension and vascular dementia. It's an important risk factor. Now, more recently, it's been shown that hearing loss is an important risk factor for dementia. So hearing loss and depression are two important factors. And they are both modifiable. You know, in the United States, there are lots of people with hearing loss who do not wear hearing aids. And one of the reasons is that in the United States, hearing aids are terribly expensive. So Frank Lin, who is the head of the Cochlear Center, he has lobbied for a law that allows people to buy hearing aids in pharmacies and supermarkets over the counter. And so this is another example of the importance of early prevention of dementia. And again, as I said, the sooner, and as Rachel said, the sooner the better, of course. Because, for example, for cardiovascular disease, you know, by the age of 10, you already have a lot of fatty streaks. And by the age of 18, people have done studies of autopsies from the people who died in Vietnam War, it shows that a lot of the more advanced lesions, as much as 30 to 40%, are already present, including, you know, atherosclerotic plaques, calcified plaques. So again, Rachel said something, you know, most things in public health are not terribly complicated. So when she said something is terribly important, we have to start prevention as soon as possible, early in life.
And you did raise an important topic that we didn't talk about this morning, about hearing loss, which is a great example and also a great opportunity to prevent policy. I'm not an expert. I don't know what's the situation in Israel and is it very costly. But this is definitely something that can be, something can be done about.
Yeah, remember that hearing loss also causes depression, loneliness. So, and people say that those mediators, in addition to a direct relationship, but the mediators also have an important role in the development of dementia.
Anybody wants to ask? Yeah, you want to come here and talk to Moyses? Professor Zuckerman is coming to ask you a question here.
Sure. Oh.
She's an endocrinologist.
Okay.
Yeah. So I wanted
You
to
know,
ask.
it's interesting that you're an endocrinologist, because an important risk factor for dementia is hypothyroidism, which is also correctable.
I thought you said it's being an endocrinologist. But, okay. What I wanted to ask is, we've been discussing a lot today about healthy aging or fast aging or successful aging, and I think one of the problems in this area is that, as you said before about death is the only outcome that we can be sure about. Other things we're not sure about. So my question is, if you would to say, we want to build the best composite or the best set of tools or the best way to assess healthy aging, how would you define, or would you make this outcome? What would it be composed of, or would it be one thing? So how would you go about defining this outcome, which is terribly important for this whole field to move forward?
Oh, that's a very complex question. I was talking about simplicity, but that's not simple at all. Remember, if you're 70 or older, I don't know how you define aging, but let's use age, chronological age. If you're 70 or older, chances are you already have a lot of problems, right? Osteoarthritis, and so on. Your heart may not work as well as before, and so on and so forth. So one important outcome is quality of life. I think it's terribly important for the elderly, to have quality of life with comorbidities. Now, there are some people who get to the age of 80 or 75 without any morbidity, which is not common, okay? Because at that age, the least that you can have is really hearing loss. And therefore, I don't think it's possible to define one outcome when you study the aging. For example, mortality. Well, mortality is the end outcome, but in between, you have the issue of quality of life. So this is important. Let me also talk about the methodological issue that has created a lot of confusion. In epidemiology, we use the relative risk, which is, it could be relative risk of mortality or relative risk of incidence, which is the incidence of mortality in people who have the risk factor or who are exposed to risk factor, divided by the incidence of mortality in people who don't have or never had the risk factor. And again, incidence, I forgot to mention, incidence is the ideal outcome because it has to do with primary prevention, right? So if you do the relative risk, as people get older and older and older, right, the denominator of the relative risk, so incidence and mortality in people who are not exposed, it will go up and up and up and up. And as a result, the relative risk will go down and down and down, leading people to conclude wrongly that because the relative risk diminishes as you get older and older and older, that risk factor is not so important. But if you calculate the absolute difference, you see that the risk factor may still be terribly important. So I keep saying something that may be exaggerated, but I believe in that. If you're interested in policy, forget about the ratios, relative risk, hazard ratio, odds ratio. Think about absolute differences. because what you want as a policymaker is to reduce an absolute number of cases and or deaths. It's not the ratio. The ratio can be enormous. Take aplastic anemia, for example. It's 7 per million in the United States. So if you have a risk factor, say you can have 12 per 2, divided by 2, that's a relative risk of 6, enormous. But in fact, from the public health viewpoint, the disease is so rare that that relative risk is not a public health problem. I think I mumbled a little bit. I'm not sure I answer your question, but the basic thing is that you want not to stick to one kind of outcome. You want mortality, you want incidence, you want quality of life, and you may want life expectancy as well. Now, Linda Fried, many years ago, came up with a single score, the frailty score, right? And some people use the frailty score as an important outcome. I think it's an important outcome, but as all scores, the frailty score assumes that the risk of developing frailty is the same for all the components. And so this is the problem with all scores, including metabolic syndrome and so on and so forth. But it's useful for the clinician mainly because when you have frailty, all the issues that I mentioned, quality of life, incidence of cardiovascular disease, and so on, cancer, go up. Not simple.
Thank you very much. And you gave us another tool. We should be aware of which measure of risk or of outcome we're using, because it may be critical, especially in old age. Moyses, thank you very much for being with us. I forgot telling people that Moyses is with us from Maryland, so there is a time difference of 7 hours, and he made the effort to join us. So thank you very much.
Oh, my pleasure. Thank you for the invitation.
Okay.
Can I go, Rachel?
Yeah, you're free.
Okay, thank you.
Okay.
If you need me, just either call me up or message me.
Okay.
I'll be looking. Okay.
Thank you.
Take care, everybody.
Thank you.
Thank you for the opportunity. Bye.
Bye-bye.